I'm Dr. Evan Schoenberg at Georgia Eye Partners, and this is a routine DMEK technique as of October 2021. We don't use any anesthesia other than topical and intracameral lidocaine. I'm using a 2.6 millimeter keratone and marking the cornea with an 8 millimeter circular corneal marker. A price reverse Sensky is used to score the periphery of the marked area. And after scoring, I bring the endothelium inward 360 degrees before completing peeling. This reduces the risk of having peripheral pulls of endothelium outside the desired area. You can see inferiorly that an LPI, a laser peripheral iridotomy, was fashioned prior to surgery. This patient is phakic. He desires eventual cataract surgery, likely with an extended depth of focus IOL, and so we'll perform the DMEK first and then return later for the cataract surgery. I've split screen here to highlight the difference in clarity of the cornea between the stripped and unstripped areas. It's important to be very careful to avoid engaging stroma with the reverse Sensky, especially in the centra. We had one small tag that didn't come away cleanly during the initial stripping, but now we can see a nice clean red reflex. I use my manual irrigation aspiration to remove the cohesive viscoelastic. It's very important to use cohesive and not dispersive viscoelastic so that you make sure there's nothing that can possibly be retained against the corneal stroma, as this would produce a substantial haze in the interface between the graft and the host. We've instilled a little bit of myostat to bring the pupil back down as it expanded during stripping. I use a modified Jones tube which fits nicely and snugly into the 2.6 millimeter incision. This is patient-ready tissue from the Georgia Eye Bank. Once the graft is in the eye, do not remove the injector until I have decompressed the anterior chamber using a 27 gauge cannula for the side paracentesis. The initial half fold is converted to a trifold with a small burst of fluid through the side paracentesis. We've achieved an orientation of the graft which allows pinning it in the corner and using pressing and releasing motions in the exterior of the cornea to unfold it step by step. The S stamp, which has been placed there by the eye bank during initial preparation, is clearly visible, demonstrating the graft is correctly oriented. I try to use peripheral motions to move the graft into more or less the desired location prior to placing a tiny, and by tiny I mean 0.01 cc air bubble behind the graft, expanding the depth of the anterior chamber a little bit, and then any spare bubbles being moved to be behind the graft rather than in front of it, allow us to then complete the unfolding action, gently pressing and releasing on the periphery until the graft is nicely unfolded. Small golf stroke can be used to position the graft exactly in the area that was stripped. I generally strip same size as my 8 millimeter graft, neither larger nor smaller. With a small bubble in place to support the graft, we will then place the larger bubble behind it. I use SF6 gas, and I'll aim for an approximately 85 to 90% fill of the anterior chamber. It's important to have that meniscus 360 degrees to know the inferior PI is going to be patent. I'll check the patient in 15 to 20 minutes with a slit lamp and make sure that we can see a nice normal meniscus, and then again they'll be seen the following day. Thanks for watching. Please feel free to reach out if you have any questions or comments.